which is once every 3 months. So we'll see how that one comes out. But that's very early yet. So once a week seems to be the coming standard. There were 2 other ones out there that are looking to be once a week.
Can you inject yourself?
Oh yeah,
Oh.
not coming to me. That would be burdensome on the system. No, we teach you to do it. These injections are just like insulin. They come in the same kind of pen that insulin comes in. They're very simple, they're very tiny needles. And they can be used, they're not approved for use with insulin, but we cheat and do it that way sometimes. TZDs will also lower glucose. TZDs preserve beta cell function, but they cause weight gain. And so that is a reason that they're not used very often as first line anymore, even without their list of things that people worry about. So any one of these things will lower blood sugar fairly well as single therapy. And then your physician can decide what's the best one for you. If your issue is that your fasting blood sugar is too high, metformin will lower your fasting blood sugar. It works at the liver. DPP-4 inhibitors, GLP-1s, work primarily at post-meal blood sugars. So what your doctor needs to do is to look and say, when are your blood sugars high? In the morning or after breakfast, after lunch, after dinner? I have the right medicine depending on what is right for you, not across the board, random guess. That's why this woman who gets metformin with no blood sugars tested makes no sense to me. What's the right drug? If your A1C is higher than 7.6, remember your target is 6.5, ACE says no single therapy will get you there. Start with combination therapy. This makes sense because one of the big issues in diabetes management is what we call clinical inertia. And if you look, it takes the average doctor, average patient, 2 to 3 years to change therapies, even when the first one is not working. Why does that happen? What happens for a couple of reasons. One is, I bet you've heard this one or said it, give me 3 more months, doc. I promise I'll be better the next time. I was off my diet, I had to fight with my daughter, I had to go to a wedding, whatever it is. There's always a reason why you weren't good the last 3 months. And you know what? The next 3 months look the same. You can't, so, I mean, you really just can't keep going this way, making excuses as to why it didn't work in the past 3 months. Now, some of this is guilt on the part of the patient. You know, they know they didn't do what they were supposed to do. They didn't check their blood sugar enough. They went out to eat too often, and they don't want to admit that they failed. So they want to give another chance. But at some point in time, you say, we simply can't go on saying, giving you one other chance, because we're not going to get anywhere. We have to do something to make this different. So the doctor also has inertia from his side, because he's not going to talk you into another medication, make another prescription, do more testing, and that's okay for just another pill, but if now you've gone to injection, it's another leap forward. The patient is reluctant. It takes more time to teach them. The doctors end up saying, okay, next time. We'll see if you next time. So I can't tell you that I'm never the same way because I get busy and you know this is going to take more time. But I try to say, this is it. It's either, if I give them one more time, I said, if you're not at goal next time, we're starting insulin, we're starting injection, we're starting whatever it is we're starting next time. Be prepared. There'll be no way out the next time you come. Or if they're bad enough this time, it's you're not leaving without doing this today. And I've discovered if I tell the patient, you're going to inject drug X, drug Y today, and they say, I said, yeah, no, today. They all walk out of the office injecting themselves with something because they know that I'm telling them the right answer and I'm not giving them any escape. So and once you've done it, and once the patient has done it, it's, what was that all about? That's no big deal. I could have done that a long time ago if you just told me. Well, I told you, but you didn't hear. So, very important to do that. But again, you want to not make the patient feel like a failure. So you put them on one drug which you know isn't going to work, and they come back 3 months later and it's not working, why not skip that step and get there sooner? I tell the patients, if you change your lifestyle, if you lose 30 pounds, if you exercise, we can take the drugs away, but why wait to make the blood sugar normal longer when we know we're damaging your organs by waiting all this time? Let's fix it now. We can always back off later if something changes. And if the A1C is above 9, you're almost always going to need some kind of injection to get this down. Usually insulin at that point in time. So the goal is to get sugar down to a physiologic profile as close to normal as possible, and may require dealing with all these multiple defects that I talked about. So this is another way to look at these things, all the medications that feed into all these different locations that one can add. And you can see up at the top the GLP-1 analogs, receptor antagonists, DPP-4 inhibitors added to this picture here. And there's actually more drugs and more categories that we can throw in here. There's cycloset, which works on the brain. There's a new class of drugs that are called dapagliflozin, which works on the kidney. We got more ways to think about how we can get the blood sugar under control. So this is the list of some of the things that you can get. The list only grows all the time, and the categories grow all the time. So it's not an easy decision. It's not one that I think most patients can make with an educated guess. It really requires talking to your doctor and saying, what's the right thing for me out of this collection of choices here. I'm not going to go through all these things because they're all there. But the other issue is, once you prescribed it, is the patient actually taking it? So this looks at adherence to various classes of drugs and see how well patients do when they give it to them and do they take it. The adherence for diabetic medications is 50%. So if you write a prescription and the patient doesn't take it, not obviously going to work very well. And are my patients better than that? We all think so. But, you know, I have many patients come back and say, I give them the list of drugs every time they come. Is this what you're on? Yes. Come back the next time and they say, is this what you're on? I've never taken this drug. Well, you've refilled it 3 times. What do you mean you've never taken it? Well, I didn't really want to tell you before I didn't like the drug, so I just didn't take it. And I didn't want to bother you, so I didn't tell you. So you don't always get the straight answer. We don't pill count. Dr. Green and I now get stuff from the insurance companies all the time saying, your patient may not be taking the drug, they've not filled it in an appropriate time frame. That's a good clue that this is not happening. I used to work at the VA, where we knew this all the time. You know, they'd come back, you know, for a refill, you know, and they hadn't filled the prescription in 18 months, they claimed they still had pills left over. That worked out well. So, if we can sort of summarize what we know about type 2 diabetes and what we want to do. We know that tight glucose control will reduce the risk of microvascular disease, and we hope reduces the risk of macrovascular disease. Less eye disease, less nerve disease, less kidney disease, less strokes and heart attacks. Harder to prove the last 2, but we still think so. To get there is not easy because there are lots of defects in the system, but we have medications that can address these various defects. And you have to take a physiologic approach to what's wrong with any one individual person, because it's not the same for every single person with diabetes. There are lots of classes out there, all of which work in different ways, and earlier use of combination therapy makes the most sense to get the patient there, to give them the satisfaction that they have achieved their goals. And we can do this the majority of the time. In my office, with a target of A1C, our average A1C in our patients is 7 or 7.1. So we have achieved the ADA goal. Really? If the average is 7, half our patients are above 7, half are below 7. So we've achieved it for the aggregate, but not for all of our patients, because it is still hard to do. And so we struggle every day with the folks who are on the wrong side of 7. I'm going to stop at that point because I think my time is up. And I have to play tennis in 25 minutes. Thank you. Questions? Yes.
No question, but I saw, I think it was on 60 Minutes the other night, this doctor's on a national campaign that says sugar is poison.
Oh yeah, no, I saw that too.
Did you see that?
I did.
It was interesting. I don't know your thoughts. Or...
You know, obviously this is an oversimplification of life. And what they're actually trying to say in that show was that what sugar does is affect vascular reactivity and metabolism of substances which deposit into arteries and increase your risk of vascular disease as well as cancer, that sugar is feeding cancer cells. And I can't argue with what he says in general. Well, I think it's an oversimplification. We know, for example,